Hello, everyone. Thank you for joining our virtual event, The Case for Cancer Screenings. As October is Breast Cancer Awareness Month, this event aims to provide more information about breast health and the importance of breast cancer screenings. With the double impact of COVID-19 and anti-Asian violence affecting Oakland Chinatown neighborhoods, more residents are delaying critical screening appointments out of fear of leaving the safety of their homes to visit healthcare providers. My name is Irene Lowe. I'm a general surgeon at Epicare, as well as the chair of our local area board of the American Cancer Society. I am honored to be sharing the stage with a few of my amazing colleagues, Dr. Elaine Lee, Dr. Michael Min Yan, Dr. Davina Ma, and Ann Nguyen. Our experts will be discussing the importance of regular cancer screenings, providing information about breast health and breast cancer, and sharing their roles in the management, treatment, and supporting care of breast cancer. Our experts will also be answering general questions about breast cancer screening. Before we begin our presentations, I wanted to say a much deserved thank you to the Oakland Asian Cultural Center, Asian Health Services, the American Cancer Society, and Epicare Partners in Comprehensive Care for partnering and participating in this important event. I am privileged to have the opportunity to introduce our outstanding panelists. Thank you, Dr. Lee, Dr. Yan, Dr. Ma, and Ann for participating in our panel. Dr. Elaine Lee is a fellowship-trained breast surgeon from Anne Arundel Medical Center in Maryland. She studied at nearby UC Berkeley before going on to the Ohio State University College of Medicine. She currently works at Epicare as a physician specializing in breast surgery. Dr. Lee sees patients in both Emeryville and Oakland Chinatown. Dr. Lee?
So again, today I would like to go over the importance of breast cancer screening. The average lifetime risk of breast cancer in women is about 12%. In another word, in a group of 8 women, 1 will develop breast cancer in her lifetime. And depending on one's family history, gynecologic history, and prior breast biopsy, you may be at a higher risk for developing breast cancer in your lifetime. Breast cancer screening modality changes depends on those risk factors. As early stage breast cancer is asymptomatic, for average risk women, screening mammogram is recommended starting at the age of 40. It is also important to perform self-breast exam, as there are times where mammogram can miss breast masses. Furthermore, breast mass can develop in between the time where a woman gets their mammogram. A self-breast exam should be performed with the woman laying flat or in a sitting or an up. And things to look out for is new onset of sudden breast asymmetry where one breast is bigger than the other, new skin dimpling or nipple retraction, or new breast masses. Breast cancer is treatable when detected at an early stage, but the key in treating breast cancer is early detection. But why do breast cancer occur? Majority of the time, it is a completely random or sporadic event. Just like how men have prostate cancer because they have prostate, women have breast cancer because they have more breast tissue. 15% of the time is due to a genetic mutation, which makes a woman more prone to develop breast cancer or any other type of cancer. But simply having a breast cancer diagnosis does not mean the entire breast will have to be removed. With the advance in medical technology and a lot of other treatment modality, it makes breast conserving surgery possible. So there are multiple doctors who work together to take care of a breast cancer patient. You have me, who is a breast surgeon, then a medical oncologist, and a radiation oncologist. And we all do something different to help take care of a breast cancer patient. So what a breast surgeons do is that they can surgically remove the cancer in the breast or even in the lymph node in the axilla. The medical oncologist can give medicine to help shrink the cancer or to lower the likelihood of the cancer coming back. And the radiation oncologist uses radiation to lower the likelihood of the cancer coming back in the breast or even in the axilla. But we all work with patients to come up with their own individualized treatment plan that is tailored to their needs. And with early breast cancer detection, breast cancer is very treatable.
Graduated from Peking Union Medical College in China. He pursued cancer research at Case Western University in Cleveland, Ohio, and then finished training for internal medicine and oncology in New York and UC San Diego. He enjoys his work as he can help take care of patients in great need, particularly those with breast cancer. Dr. Yan sees patients in Emeryville and Oakland Chinatown. Dr. Yan?
My name is Min Yan, one of the medical oncologists. Thank you for the introduction by Dr. Low, and thank you for the presentation from Dr. Yilen Li. I'm one of the medical oncologists. I work with EpiCare Emeryville, Oakland office. As folks today, of course, will be on breast cancer. I'll provide my perspective as a medical oncologist. I really think breast cancer, the more we know about it, the less scaring it is. It does not have to be that scaring. In my practice, I saw a couple multiple common myths around breast cancer. Some people think talking about cancer or breast cancer causes cancer. I think that's apparently wrong. By burying our head in the sand does not prevent the danger. It's talking about cancer. Certainly we should talk about cancers, particularly how we can do the early screening to prevent it. People also, some people believe herbs can cure breast cancer. I definitely admit there are anecdotal stories that herbs are beneficial, but the herbs are highly unreliable, and the benefit most of the time cannot be repeated consistently between different patients. So therefore, we should not risk our life and health depending on some anecdotal stories from friends or families, particularly in the early stage cancer where the cure should be achieved. Now, a breast cancer diagnosis is automatic death sentence. That's another common myth. Nowadays, we do know in early breast cancer, the cure rate can be as high as 98%. And we all around us, we all see breast cancer survivors. They're doing very well. The next one is as a cancer doctor, I get asked a lot is people think, okay, doctor, if we put a needle into the tumor to do a biopsy, my cancer might start to spread. You are going to stir the cancer cells will be disturbed, it starts to wake up and move around. That's actually wrong. We actually had a study, not particularly for breast cancer, but for pancreatic cancer. The red line here in this graph represents people who had pancreatic cancer who had a biopsy done, and the other blue line represents people who did not have biopsy. They actually do the same in terms of their outcome, and people who had a biopsy probably even did a little bit better numerically. So the bottom line here is doing the biopsy, putting a needle there does not lead to cancer spreading, and we should not worry about it. We should not delay the diagnosis. Now, there is a certain order how we treat breast cancer. Surgery is essential. Chemo sometimes is offered before surgery or after surgery. After that is radiation and hormonal therapy. We're going to talk about them briefly. The radiation therapy, I want to give you a quick summary. Radiation therapy is, for radiation therapy to be given, the patient will lie on the bed and the radiation will be delivered to the patient, to the area of the breast or to the breast, the same side of the breast where the cancer occurred to prevent the cancer from coming back. And there's a chemotherapy. Typically, patient is hooked up with the IV line for the chemo to be given. And hormonal therapy, most of the time, is patient will take a pill every day. Couple questions often asked by patients who were diagnosed with cancer. The first question is, my cancer is gone after surgery. Why does my doctor still want to give me more treatment? Because the reason here is because the cancer cells actually can leave the primary location and hide in distant organs. Here in this picture, in the background of normal cells, you can see that there's a cluster of cancer cells hiding in there. And this, we call this micrometastatic disease or micrometastasis. So this micrometastatic cluster of cells need to be eliminated. Otherwise, they might come back over the years and cause cancer relapse. And we use hormonal therapy and chemotherapy to help get rid of them. So another question from a patient is, my friend takes a pill for 5 years. What is that? Well, that pill is most likely the hormonal therapy or endocrine therapy. Cancer cells in around 50% of the breast cancer cases need female hormone to drive their growth. Here, there's a cancer cell that is so-called ER positive. ER represent estrogen receptor. So when the cell has estrogen receptor, the estrogen is a female hormone that can bind to the receptor and drive the cell to grow to multiple cells. But when the patient gets hormonal therapy, the estrogen level will often drop to a low level and the cell will remain quiescent and not grow. So hormonal therapy is almost always offered to this type of cancer patients for at least 5 years. And I'm going to skip this graph showing there's a remarkable benefit for people in the right patient population, people will benefit for the cancer not to come back. So another question I get asked is, my friend did not need chemo. Why do I need it? Or sometimes people ask me, my friend get chemotherapy. Why do you not offer it to me? So the answer is not everyone really needs chemo. Not every cancer is the same. For a group of patients, we order a test called Oncotype. On this slide, you can see, I'm not sure I can see the cursor there. I hope you can see the cursor from my mouse. Here, you can order this test. You can divide the patient into 3 groups. There's a low risk here. In this group of patients, the cancer does not really come back in 97%, 96% of the time. So whether you give the patient chemo or not does not really change much. So those patients do not need chemo. There's a high risk group where if you do not get chemotherapy, there's a risk of 60% of patients can go for 10 years without cancer coming back. In other words, 40% of them may likely have a cancer relapse. That's probably too high a number. And we want to give chemotherapy to make that risk much, much lower. It does help. So we would offer chemo to this high risk group, but not to the low risk group. And we'll do a discussion with the patient if they have an intermediate risk disease. Hopefully that makes sense to you. So is chemo bad for my body? In the short term, I think patients could have fatigue, hair loss, nausea. It's not a good thing to have, but in the long term, it is very uncommon. People could have long-lasting permanent damage. There's a common conception that chemo may kill patients. There's reason for people to think that, and part of that is also because chemo was offered at a too high a dose to people who already has cancer in their very late stage. Nowadays, we do a much better job, and that rarely happens. So chemo is really only recommended when the perceived benefit is substantially higher than the risks to help patients, such as the one you are seeing on this graph. You can see the great benefit. Whoever gets chemotherapy actually live much, much longer without cancer coming back. So, all right. There's HER2 protein in a certain group of breast cancer patients, and HER2 targeted therapy will be offered to this group of patients. For time's sake, I'm going to skip this slide. Sometimes we offer chemotherapy before the surgery is given. One of the major benefits is that if most of the time, chemotherapy will make the cancer much, much smaller, so the surgery is easier. And it also, if the cancer is smaller or become absent after chemotherapy, that's a surrogate marker for us to know that any potential micrometastasis I showed you earlier is likely going to be eliminated by chemo already. So that means that can help us to decide what subsequent treatment the patient may or may not need. After the patient gets all the treatment done, people also ask, what can I do for myself, for the cancer not to come back? I put emphasis on good sleep. You give yourself enough time every day to sleep. Weight control, because female hormones is produced by fatty tissue. Weight control is important. And also there's from Asian patients, I get asked a lot about the soybean tofu, whether that's good or not. So historically, isoflavone is known as a plant estrogen used to be theoretically linked to a higher risk of breast cancer. That was proved from large population study to be not correct. Actually, numerically, there might be even a benefit. So bottom line is a modest intake of soy or soybean in the diet should not interfere with the risk of breast cancer. And exercise of physical activity is extremely important. There's probably 40% lower risk of death for people who are most physically active compared to people who's least physically active. So this benefit is almost comparable to the medications we use. So that's very important for us to know, not only for the patient, also for actually even for us as providers, staff. And thank you very much. And that's the end of my presentation.
She is a graduate of Harvard University and New York University's School of Medicine. She trained in internal medicine at Santa Clara Valley Medical Center and joined Asian Health Services immediately after residency. She has had the privilege of serving the Oakland Chinatown community as a primary care physician at Asian Health Services for over 15 years. Dr. Ma?
Thank you, everybody, for inviting me to participate in this panel. I think I was actually invited initially because I'm a primary care physician and to provide that perspective. And I think what people didn't realize at the time is that I'm also a breast cancer survivor and about a year and a half out from treatment. So my presentation today will be able to wrap up provide both of those perspectives and to reinforce some of the messages that we got from Drs. Lee and Yan. As a primary care provider, I talk to my patients a lot about breast cancer screening, and I get a lot of reasons for why somebody might not want to get a mammogram. Really commonly, what I hear is, "Oh, I'm fine. I don't have any problems. You know, there's no cancer in my family. It hurts." Which fair enough. I don't have anybody to take me there. That's a big one. That's a very difficult one for a lot of my patients. Some people feel like because they breastfeed their children that they're not at risk. Some patients feel like they're checking themselves. They do self-exams. They don't feel anything. They think they're fine. And of course, more recently, people are afraid of being exposed to COVID. So, some of the things that I've found with my patients, some of them have actually detected abnormalities themselves. They've found lumps, or they noticed there was some unusual dimpling in their skin, or they found that they had some breast discharge and they were not breastfeeding at the time. But I've also had quite a few patients get cancer picked up on mammograms when they had really normal exams. And so it is really important to do both, to not rely entirely on those manual exams. Well, so what is it like after you find out you get cancer? What's next? Well, I'll tell you a little bit about me, my risk factors, and this is what I tell my patients, because people who feel like they're not at risk, well, that was me. I was 41, I was breastfeeding and actually found a lump I actually thought it was a clogged duct at the time. And so I kind of tracked it for about 2 weeks, realized it wasn't going away. And I thought, I'm just going to be a little bit extra careful. I'm going to have it checked out. And so I had an ultrasound first because I was breastfeeding. And then they said, no, you need to get a mammogram. So I got the mammogram and then a biopsy, which turned out to be cancer. I had a lumpectomy, which looks almost exactly, my scar looks almost exactly like the picture in Dr. Lee's slide. And one of my lymph nodes was positive for cancer. And so I had the works. I had the 4 cycles of chemotherapy, a month of radiation, and I will be on oral medication for about 10 years. And, you know, as Dr. Yan mentioned, you know, chemotherapy is different. Now they really try to choose as low of a dose as is really effective and needed. And what I was told initially by my oncologist, you know, you have this idea in your head of what chemotherapy looks like, which is, you know, you can't move, you're throwing up all the time. And actually, we've gotten really good at treating the nausea. You know, you are definitely tired, you need to rest. A lot of people actually manage to work, you know, part-time when they're getting chemotherapy. I opted not to, but it is actually very different. I think my experience from what even my perception of it was as a doctor. And so, you know, I've recovered, you know, good predictive factors. And, you know, I've come out of that really with this desire to share my experience, you know, with my patients and with my community so that people understand. That the screening is important, the treatment is very tolerable, and that people get good recovery afterwards. Thank you.
In her role, Anne executes a portfolio of community-based fundraising events, including Relay for Life and East Bay Gala, by developing strategic partnerships with corporate sponsors, health systems, and community leaders to increase community investment and partnership. Anne graduated from UCLA with a degree in global studies and is currently pursuing a Master of Public Affairs at UC Berkeley's Goldman School of Public Policy. Anne?
Hi, everyone. Hope you're doing okay. Before I begin, I want to thank Dr. Lee, Dr. Yan, Dr. Ma, and of course, Dr. Lowe for having me on your program. Thank you for all the work you're doing as the frontline folks who are addressing issues of cancer and now COVID every day in your work, and also making time to be here today to put those issues on the forefront of people's attention. And thank you for your partnership, for partnering with the American Cancer Society to make sure that we're getting this message and the urgency of screening to folks who need to hear it the most and often not being reached by just our regular media. And so today I'm hoping to speak a little bit about just very brief history of screening, the urgency for it, and what the American Cancer Society can do at this time. So just a quick second. So cancer screening is critical to staying healthy and well. Early detection of cancer before symptoms appear transformed the world of cancer care and has continued to have a critical role in control of cancer types for which screening is available. Between 1989 and 2017, the overall breast cancer death rate declined by 40%, which is about 375,900 breast cancer deaths averted in this time period, due to a great extent to early detection with the increasing utilization of screening mammograms. Steady progress has been made in improving cancer screening rates, but as you've known, the COVID-19 pandemic could potentially reverse these gains. Continuing to improve cancer screening rates is critical as there are so major gaps to fill in decreasing the burden of cancer. And about cancer disparities. Screening is one of the earliest interventions along the cancer continuum. Thus, closing disparities in screening is an important step towards closing disparities in cancer outcomes. Disparities in cancer screening exist across groups of people who have systematically experienced greater social or economic obstacles to screenings based on their racial or ethnic group, sexual orientation, education, health insurance status, immigration status, or other characteristics historically linked to discrimination or exclusion. The COVID-19 pandemic has exacerbated these social and economic obstacles, but cancer doesn't wait, and neither should we, neither should you. So in 2021, what we found is 42% of US adults in families who lost income reported being unable to pay rent, the mortgage, or utilities, being food insecure, or going without medical care. This has disproportionately affected adults with family incomes below poverty level. So what is the American Cancer Society doing about it? We're launching and has launched this past year our screening initiative, which is using an integrated multi-pronged approach for its screening initiative so that everyone has the fair and just opportunity to prevent, find, treat, and survive cancer. The building blocks to increase screening rates include a national consortium, convening national influencers and identify strategies to best minimize the effects of the pandemic on cancer screening care and take action. Research to better understand the impact of the pandemic on cancer screening outcomes. Public awareness and campaign like what we're doing right now, which is the campaign to raise awareness and increase regular screening for cancer. Health system interventions by engaging priority health system and evidence-based interventions to increase screening rates. And of course, with our sister organization, ACS CAN, the Cancer Action Network, to pursue public policy solutions to help ensure individuals have access to timely and appropriate cancer screening and follow-up care. In our local community, what we're doing and support that we can provide range from having a 24/7 cancer helpline, which is 1-800-ACS-2345. That's 1-800-227-2345. And yes, you will get to talk to a live person on the call, and it's honestly is the beginning part of any of your cancer questions. It could help a family and a loved one, even not immediately in California, in Oakland. So definitely start there. We have lodging, which we called Hope Lodge, for folks to get access to care when they live too far from where they receive care. So here in California, we partner with hotels partners to make sure that patients and their family have a place to stay while receiving care. We also have rides to treatment, and what that means is we provide patients with travel from their home to their care provider and back. We recruit volunteers as well as help patients identify transportation to get to where they need to be. Part of that rides to treatment program is also transportation vouchers that we partner with transportation county as well as transportation programs to make sure that is taken care of during COVID. Let's see. A few other programs we have specifically for breast cancer patients is breast cancer support. We linked mentors as well as survivors who have gone through the experience with current patients so that they can create and build a bigger support system. And of course, we also have our WIC programs that provide WICs to patients who, and they're free WICs for patients who are going through hair loss. So those are a few of the services we have. And of course, we don't want to limit to just that. Please check out cancer.org as a place to gain and empowered by the education that we have online to search about what that looks like and what resources are available near me, as well as any guidelines regarding screening. So that's my short presentation. I hope you all check us out on cancer.org, as well as talk to your healthcare providers to get more detailed and specialized recommendations. Thank you.
Now, we wanted to now take this opportunity to kind of have a discussion, answer some general questions, things like that about breast cancer screening and breast cancer. So I'm just going to throw out some questions that I think a lot of people who are watching this event may have and may want some more answers to. You know, like we've all shared in these presentations today, you know, people are scared to get screened and for many different reasons. So what do you tell your patients when they come to you and tell you, I'm too scared. You know, it's going to hurt. I'm scared of getting COVID. What do you tell them?
Well, I'll usually address the COVID part first, because that is when you can more reasonably reassure people, you know, especially now with community transmission being quite low in the Bay Area, and knowing that, you know, we live in an area where people wear masks, fortunately, and, you know, you're unlikely to go into a space where somebody's been breathing you know, without a mask on. And so I reassure them it's safe. You know, I think that we've passed through the worst of it. I do at this point really recommend that people go. The pain part is harder because there is no great way to reassure people. I think, you know, for me, it's really just trying to convince people that the benefit outweighs the pain, and the pain is real. You know, you can take a Tylenol before, and maybe that'll help a little bit. But just, you know, to acknowledge that, that yes, yeah, it hurts, I agree. But here are the reasons why I feel like it's still really important.
So when would you guys say people should ideally get screened? What age and that sort of thing? Yeah,
that's a really good question, because for in primary care, a lot of us were following the U.S. Preventative Task Force's guidelines, which started screening at 50. And you know, the other major advisory bodies have always recommended starting at 40. Definitely after my own diagnosis, I started pushing at 40. But what I'm also finding anecdotally, and I'm sure there's some research that is currently ongoing, but I'm finding anecdotally a lot more younger women getting diagnosed. Compared to what I used to see with my own patients. You know, I used to really think of breast cancer as something that I would find in my 60-plus-year-old women. And I'm just hearing a lot of cases, 40, even below 40 without risk factors. You know, I actually suspect, you know, there are environmental factors involved, you know, for those of us who grew up in the 80s, you know, without, you know, the same kind of understanding of some of those, you know, hormone disrupting effects of certain plastics. You know, I feel like we've probably been exposed to a lot more environmental toxins than maybe people who grew up in the 50s and the 60s. So we are really trying to push for those 40-year-olds and up for average risk.
I would agree with that sentiment because I guess for me, all I see are breast cancer majority of the time. And you're very much correct in that sense that the cancer diagnosis is getting younger and younger. There are a couple of patients in my practice currently, they're in their 30s and they have no family history. And it is important to let patients know that while there are no family history, the mutation has to start somewhere. What if you're the one with the mutation and you're the first one in the family tree with it, and that can ultimately pass on to your children? And so a lot of times when the patient is diagnosed very young, we talk about genetic counseling for them. It's just for their other screening, cancer screening measure, because genetic mutation is not just associated with one type of cancer. For the more well-known mutation called BRCA1 or BRCA2, it is also associated with ovarian cancer. And there are procedures, there are screening measures that we do for young women with BRCA mutation to lower their risk of mortality from breast cancer or ovarian cancer. So I think it's important to, you know, talk with your family and get screening in a timely manner.
Thank you. So a question that I have for our physician panelists is, you know, obviously we've seen an effect on COVID, on screening, and also breast cancer treatment. Maybe if you guys wouldn't mind sharing some experiences that you've noted in your practice about COVID's effect. Since people haven't been able to get screened, what have you seen differently in your practice now?
I think encouraging patients to get their screening mammogram in a timely manner is a struggle. I recall seeing some patients who have a history of breast cancer themselves, where they are due for their annual surveillance mammogram, and they would defer saying that it's already a struggle for me to come in here to see you. I don't want to take more risks to get a mammogram. And I have to remind them, well, it's great that you show up to see me where I can do a good breast exam on you. There are times where cancer recurrence is not appreciated on a physical exam, and it's manifested on whether it's a mammogram or an ultrasound. So I do kind of strongly encourage them that if they are fully vaccinated, they wear their mask at all times. It is perfectly safe to go to an imaging facility to get their mammogram.
My experience in the past few months has been that I did not see a remarkable increase of patients whose cancer was delayed by the COVID-19. That's my personal perception. But I kind of suspect the reason is most cancer grow slowly. So even if you don't do mammogram for a whole year, that doesn't mean the cancer will grow that fast, and you're going to see them. Just because you did not do mammogram in 2021 or 2020 does not mean you're going to have a big cancer in 2021. However, keep delaying the mammogram will, I think, in the long term, results in a big problem. There might be a small surge. By the time I think this recording is being made, I think we are hopefully getting to a close, getting to the end of this tunnel. So I would encourage the audience to get screening if it's indicated.
So another question that patients are having nowadays is, with the COVID vaccine, sometimes they can have some, abnormalities or growth in their armpit lymph nodes. So what is the current advice for patients to get their mammogram in relationship to their COVID vaccine?
I've seen a certain imaging institution where they recommend at least a 4 weeks to even upwards to an 8 weeks wait from their last COVID dose, just so that the lymph node has the time to kind of return to its normal state prior to imaging. Initially, when this whole COVID lymphadenopathy came up, at least at Carol Ann Reed Breast Health Center, they were saying wait 4 weeks. This is actually the first time I heard to wait 8 weeks. What have you heard?
I'm not. I guess every imaging facility may have their own protocol guidelines, as we know better the dynamics of the size of lymph node. So what happens is a vaccination. Well, first of all, the vaccination works by inducing an immune response, which can lead to a big lymph node underneath the arm, which can confuse or mislead the radiologist, because people may think, oh, you might have cancer in there. So for that reason, I think most imaging facilities are designing some protocols for people not to image it, or if we have to do the image, we have to keep that in mind. Whether 4 weeks or 8 weeks, it might be a good idea for our patients to double check with the facility before you show up. In the long term, it may not be a big problem as we all get the vaccination, but still, that's good to keep in mind. If you do get the vaccination, and double check with the facility before you go.
Thank you. I think, another fear that our Oakland Chinatown residents have nowadays is the fear of anti-Asian violence. It's become a problem across the country, but particularly in our Chinatown neighborhoods, it's much more real and it's happening. What do you guys have to share with those patients who are worried for their lives to get screened?
This might actually be one case where the facilities being in another neighborhood is actually to our advantage this year. You know, historically, I actually have trouble getting people to get mammograms because we don't offer it anywhere in Oakland Chinatown. And so I've actually found that while patients are reluctant to come into Chinatown, that actually has not come up as something as a barrier for them going to one of our other imaging facilities. I think the fear of COVID seems to be much more prominent there.
For patients who are, interested in learning more, trying to figure out how they can decrease their risk of breast cancer, what advice do you have for them? I know obviously they need to get screened, but is there anything else they can do on their own to try to decrease their risk?
I think everybody that I've talked to in my own journey has strongly urged a plant-based diet. So I think that's up there, really minimizing the amount of animal fat in your diet, increased exercise. I think beyond those two, I don't know if there's anything more powerful in that combination.
Actually, as a medical oncologist, I see quite some patients who are cancer survivors who's already treated, cured. What I personally noticed is there's a small group of patients who, after the cancer is cured, they go back to work very hard, and sometimes very stressful level, and they don't have adequate hours of sleep. Some of them sleep like 3 or 4 hours a day, and they don't. So that I noticed that might be actually a risk factor for cancer relapse. I would suspect lack of good quality of sleep might also have been a contributing factor for our younger patients to have breast cancer or even other type of cancer. The theory is when we sleep, our immune cells wake up, they circulate around the body and get rid of any residual bad cells in there. It's a time, it's like the city is asleep, the people come out and sweep off the street and clean it up. But if the street is always running with cars, and then there's no time for this to clean up. So I really think, diet, exercise, good sleep, those are very important things we need to continue to talk to our patients with.
Thank you. So before we end our event, I wanted to give all of our speakers an opportunity to share one final message with all of our viewers. This is obviously a very important conversation that we had today about breast cancer screening. So I wanted to give everyone an opportunity to share one final thought to leave everyone with, an important message. Let's start with Dr. Lee.
I guess a lot of times when I talk to patients about their cancer diagnosis and their care, their immediate inclination is, well, why me? What did I do to get this? And it's nothing that the patient did personally. It's really just a case of bad luck. And then if someone gets a screening mammogram and is detected early, breast cancer is very, very treatable nowadays.
Dr. Yan?
Right. I would say hopefully none of our audience will need to see me as a medical oncologist. But if you are unlucky and do get diagnosed with breast cancer, I do want to echo with Dr. Yilan Lee. It's highly treatable, and early stage cancer highly curable. You will be able to live a normal life. So the treatment we give to you is tailored to you, and the benefit is much, much higher than any risks. And what you can do is try your best to get a screening mammogram, and breast cancer is not as scary as it used to be or it sounds to be.
Thank you, Dr. Yan. Dr. Ma, last words?
And I would just have to echo Drs. Lee and Yan. on the importance of detecting early, on how treatable and tolerable the treatment is these days compared to even 10 or 20 years ago. To acknowledge that, it can be a little bit scary or inconvenient to have to, leave your home to go somewhere to get that mammogram. But that, the benefits of detecting a cancer in its early stages really outweigh, I think, all those, the discomfort and the inconvenience.
Thank you, Anne.
Sure, thank you. I think my last thought, coming from the perspective of a caregiver, is thinking along the phrase, like, it takes a village to raise a child, and I think it takes a village to cure cancer, right? So for someone who, may have breast cancer or think they could have, I think family members can be a great support, and to never forget that they have that support system and they're not alone in this. And, to find the resources to educate yourself, as well as rely on the medical professionals like yourself to guide them through the process. I think there are times, especially COVID, where it was very isolating to think about all the issues out there that was, against Asian Americans, and then on top of dealing with your own personal health. So just to keep in mind that there are resources out there. The American Cancer Society is out there to support virtually, but also there's the healthcare providers like yourself to support them along the way, and to never think that they're alone in the fight.
Thank you, everyone. So as we close our event, I really want to thank all of our amazing speakers for sharing their insights on the importance of breast cancer screenings. There are many reasons why many women have chosen to delay breast cancer screening, including COVID-19 and anti-Asian violence. But our hope is that through this panel discussion, we have provided you with many more important reasons as to why you need to get screened, some of which many of our speakers have highlighted today. Breast cancer is not uncommon. Regular cancer screening can detect changes in the body before cancer develops or catch certain breast cancers early. Breast cancer is treatable and easier to treat if found early. Cancer is not a death sentence. Cancer treatment is well tolerated. There are risks, but the benefits outweigh the risks, and more treatment options are available if the cancer is found early. There are also various programs and services available to help you obtain your cancer screening and cancer treatment support if needed. On behalf of the Oakland Asian Cultural Center, Asian Health Services, the American Cancer Society, and Epic Care, I want to extend a huge thank you to everyone who tuned into our event, The Case for Cancer Screenings. As we have discussed during this event, cancer screening is extremely important and necessary. Cancer, unfortunately, does not wait. We strongly encourage everyone to please get screened. Screening can save lives. So thank you, everyone, for participating.